Hello, today I am here with Dave Elton. Dave is a fellow chiropractor with a really different background than most chiropractors. Him and I probably align more in that we've spent a lot of time working with physicians and physician groups. But Dave's got a great background. I'm not going to try to fill in the story, but rather ask him to do this for us, and then we'll get into some questions. I'm very curious about what he's up to now and where he sees conservative musculoskeletal care going. So, Dave, welcome, and glad to have you here. You have such an awesome background of knowledge, and I'm excited to talk to you more. But would you mind giving us a little bit of your background?
Yeah, I'll do that. Hey, thanks, Mark, and thanks for the invitation. Look forward to the conversation. So, background, picking it up with professional training. Graduated from chiropractic school in 1986 from what's now known as Northwestern Health Sciences University here in Bloomington, Minnesota. And from 86 till early 90s, I was in the typical what's called associate, so part of a practice with a more experienced chiropractor and worked in a couple different clinic settings through the early 90s and uh, enjoyed practice. I think I started to get a little um, maybe bored with practice, the routine back pain coming in and just um, not that practice is boring because there's just exceptional clinicians, as you know. For me
Yeah.
personally, it started to become, boy, this probably isn't my path. But towards the end of my clinical tenure, I got connected with a couple colleagues, Dan Pavlik in particular, who's a chiropractor in Florida, who was ahead of his time in that he was developing a multidisciplinary physical rehabilitation based practice with chiro, PT, exercise. I think we might have had an ATC or two, and we had three practices in Minnesota and several in Florida. And so we were a multi specialty physical rehabilitation environment, largely a referral practice from other chiros, from medical physicians, from employers. We did a lot of work comp activities. And that was that for me, that started to become really interesting and fun. And so in the early 90s, it became evident to me, though, in that as a referral based practice, that man, we need to have a measurement platform in place. Like, how do we systematically capture outcomes? How do we put in functional measures in place? How do we do consumer ratings? How do we add in cost measures for our direct cost of care and practice? And so built the measurement platform for the practice that allowed us to go out to our referral sources and say, hey, here's our value proposition, here's what we're doing, and then do that systematically at scale. And in my career path, as you know, it's a relatively small community, really,
Yeah.
that we practiced in the Twin Cities here with Tom Allenburg, another chiropractor who, visionary, another one, who started up at the time an entity called Chirocare, which was effectively a PPO network. That Tom's thesis at the time was, hey, this insurance coverage is moving forward. Chiro's at risk of being left out. We need to apply credentialing. We need to do some things to organize to get us into the insurance game. And that entity scaled to become American Chiropractic Network, to take the Chirocare model nationally. And Tom and I got to know each other. He said, hey, we need to do some systematic measurement across our entire network. And the main reason I was brought in was, can we use those kind of measures to tier a network to line up what at the time was relatively new, but has since become standard practice around utilization management, the prior auth stuff that, you know, is sort of
Yeah.
the bane of everybody's existence, right? Like, oh my God, what are we doing? But he said, hey, I want you to come in, use measurement to identify practices for whom we don't need to do on. I'm like, oh, that sounds really interesting.
Hmm.
And so did that with ACN. ACN scaled. And then in 2000, roughly, we were acquired by United Health Group that was looking at us to um, sort of be a vendor to manage their chiropractic and PT benefits, but they ended up acquiring us.
Did
And I'll
that
tell you what,
stay? Good. I'm sorry.
no, I mean, I talk about pure serendipity. I could not be hired into United Health Group. I mean, that's an environment filled with just exceptionally talented people. So it was serendipity, but for someone that at the time, um, without training, but was comfortable with at the time big data. How do we analyze this? How do we tier providers? How do we segment providers? How do we, um, wow, talk about a dream setup for me as a clinician with some data aptitude to now go into United Health Group.
Yeah.
That was pure serendipity as I managed. There was no plan there for me personally.
Right.
But with that opened up, now we, as a business unit, we're a capitated entity. So we manage the capitation arrangements for insured members at scale for United Healthcare around the country, do clinical operations, professional relations, a lot of Department of Insurance and regulatory work. And, it was, looking back, I mean, I could not have planned it to gain the kinds of experience I gained inside what has now become, United Health Group, this enormous
Yeah.
enterprise.
Yeah. Yeah. That's amazing. Do they still, is ACN still, American Chiropractic Network, still called that, or has United Health Group called it something else now?
No, well, that's funny actually. I mean, within UHG, you say ACN, people still know what
They
ACN
do.
is, but that
Yeah.
went away long ago. Now it would be known as the Optum Physical Health Business Unit. So it rolls up under Optum, Optum Physical Health, Chiro PT, Acu Massage, and um, no, I do look back fondly at the people I got to know, the experiences I um, had, which just were laid in front of me. It was just terrific.
Yeah, I bet. I don't want to jump the gun too quick to get to the punchline of what you learned there and experience. But I do remember I got out of school a few years after you did, and when PPOs were coming around, and I was in Southern California, and Pacificare
Sure.
was one of them, and we had no idea why we wanted to join any of those, right? Like it sounded like sign up for less money. And
Yeah.
no, even the physicians that I knew then had no idea. But and the downside about that when that was happening is was when I applied, they're like, oh, you got to be out of school a minimum of 3 years
Right. Oh yeah.
before you can get involved.
Yeah.
And
Yeah.
you know, as a new grad and as an associate like you, I just struggled to gain acceptance in the community,
Yeah.
a community of, millionaires in Newport Beach. I sure didn't fit in anywhere. I wasn't running around with those
Yeah.
people, and struggled for a long time. And even back then, you probably remember as well as I do. I mean, we were called quacks to our face,
Yeah.
or at least I was, by a lot of people, which I grew up with chiropractic. I had no idea that was how we were viewed. And I'm going to
Yeah.
do a different podcast on how that came about, but different topic. Um, so I did the same thing. Is I tried to measure outcomes as well, kind of rudimentary, to try to show my value and worth. I was doing a lot of work comp at the time, and part of the work comp guidelines in Colorado was to use outcome measures. And so I was using, I believe, functional rating index. But you said you guys built a platform. What were you tracking, and how were you tracking that?
Yeah. So and this is in the ACN context. We, for good or bad, and clearly on the practice side, it's it was a bad thing. And looking back on it, we're like, wow, was that antiquated? But for these practices, we looked at it, and it's the clinical record keeping, and people were still using pencil and paper, right? I mean,
Yeah.
it was old school. And we looked at some of the record keeping. We're like, wow, we need to standardize this. So we put in a standardized intake form. And then when I was brought in at the time, we looked at, okay, what standardized outcome measures could we bake into the intake and ongoing measurement of function? And oswestry, NDI were classic. They were similar, 10 questions, similar format, easy to administer. Over time, we added dash, lefts, keel, start back, and then we did consumer ratings. At the time, it was, sort of this big, um, you know, 20 question, I think it was CAQH or some survey that burdened patients with a lot of questions, which over time evolved into just net promoter score, text field, why did you rate us the way we did? And then you apply some analytic tools and you can decipher everything out of 2 questions.
Yeah.
So it evolved over time, but it was built on this. We need to standardize clinical note keeping in a paper environment. And then providers would submit that to us, of all things, and then we manually enter it. But at the time we're assembling this database that was quite impressive. And this largely was before a lot of the the EHRs that we have
Sure.
today. And so our colleagues, to your point on quacks within United, were like, whoa, here's this chiropractic business unit that has standardized clinical data submitted for hundreds of thousands of patients a year, including public domain outcome measures. Like, we ought to pay attention to this. And not only data for data's sake, right? And not only to accomplish the objective, which we'll probably get into, but we now have this pool of data matched with claims to be able to measure at a provider level variability in decision making and outcomes and value, and use that data for good, we thought, which was not to beat people up with it, but was more to share how are you performing compared to your colleagues and help elevate everybody. So it was, to the point, this pure serendipity to get in, but then do what we think still today looks like really good work at the time,
Yeah.
just from a healthcare perspective around
Right.
standardizing clinical data and using it for good was, amazing experience.
I'm sure people at the top and inside wanted to see what the outcomes were and whether it was cost effective care. What were you seeing as you were gathering that much data, and what were they doing with it? What was the people at the top? What was their level of excitement or concern? Either way.
I clearly, the medical directors um, were impressed and probably a little envious that, wow, you can corral a network of, I forget at the time what it was, but let's just say 20,000 providers
Mm-hmm.
all around the country, put them on effectively the same medical record, the same clinical data, match it with claims, roll in outcomes sequentially. Impressed that someone could just do that, right?
Yeah.
And which I do think helped, sort of reduce some of the stigma around, well, you chiropractors are quacks. It's like, oh, you guys are serious about this. And so again, it's Tom Allenburg had the vision on this. Like, okay, wow, yeah, you've got something here, which is impressive. But then you get into the so what, and consumer ratings and reviews, as universally high, no differentiation among providers. Patients are really highly satisfied with this form of care.
Right.
Personal, hands-on, get to know you, um, and so you know people. And I roll it forward a little bit to the net promoter score era, where something like Apple or some of these brands that are held out there as strong have net promoters 70, maybe 80. year over year, market over market, Chiro's net promoter is 90, 92%.
Wow.
Like exceptional, really high. And people are looking at that going, whoa, what's going on there? And beyond that, you almost don't get to the outcome like change in oswestry score, which kind of didn't matter. It was good we were doing it. It's nice to have it. But consumers are the ultimate evaluator of outcome. And when their net promoter is running 90 plus,
Yeah.
that tells you something really good is going on, which then we start to look at, right, measurement has a cost. And if you're imposing this burden on an entire delivery system to do pre-post outcomes, oswestry longitudinally,
Yeah.
it's a classic CBA. It's like, wow, if we're getting all we're getting from one question with the consumer, why do we need to place this burden on everybody on oswestry, even though people think it's valuable? Now, a quick sidebar, if you entertain it. So during the opioid epidemic, again, to the point of just a blessing to be in an entity like UHC. Musculoskeletal complaints drive a lot of opiate prescribing. I was on the UHG opiate task force. We were looking at what can we do. Clearly, a payer is not going to solve that, but we can create conditions to be helpful, which we landed on benefit plan designs that eliminated patient out-of-pocket costs when visiting a chiro or PT for back pain. Think about that.
Yeah.
To get a payer to get to the point that we're going to remove out-of-pocket cost to reduce or eliminate that barrier to people accessing this kind of care. And that was, a couple years of work. And what didn't come up one time in all of that was, what's the change in the oswestry? I mean, it kind of didn't matter.
Yeah.
The avoidance benefits by that time were so clear that, the oswestry data just had very little value, really.
Clinically, I mean, the net promoter score is one thing. I've seen some studies, you've probably seen them too. People who have access to chiropractic or even start with chiropractic end up being lower utilizers of things upstream.
100%.
Right. So, and I agree, I saw people's lives fall apart once they either couldn't pay their copay anymore or their 12 visit limit was maxed out. And the argument was like, you maxed it out, or the argument used to be, well, this is maintenance, or you're not getting them better. But like you noticed, probably, but people aren't advancing into other things. And back pain, it doesn't get better. I mean, I hate to sound like the prophet of doom. I mean, once you sort of have it, it comes and goes.
Sure.
But I've never seen it just come and go and never come back.
Yeah.
Giving people access to something that's helping, regardless of whether it's going to cure them or not, seems like a no-brainer.
Yeah, I mean, that's really true. So, sitting on all this data, eventually we got to the point of wanting to do some research, and should we start publishing some of this stuff, and can we start pushing it out, to your point? And in 2002, Tom Allenburg and I had what I thought at the time was this novel idea around, because it wasn't out there. First provider scene, let's set up a whole bunch of analytics around first provider scene, follow them longitudinally and understand these different pathways. Is there a difference? That was 2002. And to your point, the first analysis that came back, right? If you start with a chiro, less RX, less imaging, less surgery, and you got to put all the controls for differences in patient complexity. And I thought we were brilliant until, I actually have it right here, until when Tom Allenburg left ACN in 2006. On his way, he gave me this folder, which was a study that he commissioned when he was at the American Chiropractic Association, looking at 1988 data that revealed exactly the same thing. And it was a first provider scene analysis. Costs are lower, less pharmacy, less imaging when you go to a chiro first. So the point is, this has been known for a long time. And I've had some interactions recently with some researchers, and then we keep doing these first provider scene studies. I'm like, yeah, this has been known for 30, 35 years.
Yeah.
What problem are we trying to solve by continuing to do the same research? We're not going to get a different answer,
Right.
which tells me the translation for us, and this starts to bridge to why a REIT a little bit, is in 1988, the percent of low back pain patients that started with a chiro was 33.9%. The last
What,
study
what was? I missed that.
the percent of back pain patients
Oh,
that started their episode with a chiropractor in 1988 was 33.9%.
wow.
When I, towards the end of my tenure at UHG, did some publishing, in the both before and after COVID period, and in the, 2020, 2022 time period, the percent of back pain starting with a chiro is about 33%. So all the guidelines, all the research, everything that's taken place in those 30 plus years hasn't changed anything
Yeah.
around first provider scene or pathways, which that gets into the AREIT thesis, which is research isn't going to change any of this. I mean, good to do research, academic pursuit, remain curious, all good. But that's not going to change how many patients are benefiting from these therapies. It's other things.
Tell us about a REIT and what you're doing now.
Yeah, so so the preamble to that is, I'll just wrap up my UHG tenure. So I
Yeah.
had a
Yeah.
chance,
Please.
because it gets to the why I read. So I um, had a chance to, in UHG, by design, people move around. You want to get different experiences, go to different business units, do different things. And I was no different, and ended up in Optum Behavioral Health. So, our mental health business, same role, capitation, affordability, healthcare economics, clinical programs, legal, regulatory for mental health for 6 or 7 years. That was fantastic. Learned a whole new area. Then had an opportunity to go to UHG Ventures, which is the venture capital entity in UHG at the time that evaluates new technology, starts up new businesses. And we started up a company called Orthology, a healthcare practice, a chiro PT practice called Orthology. Did some work in type 2 diabetes similarly. And during the Orthology period, I met who is now my business partner at a REIT, Dr. Garrett Rock, chiropractor. I think you know Garrett. He's in
I know
Colorado.
Gary. Yeah.
He was, and I forget the year, but it goes back to 2017, 18, maybe. Garrett would know. He had this thesis. He's like, I think there's an opportunity to organize practice in a different way and modernize technology. And we got to know each other and gave him my thoughts for what it was worth. Um, and then, it just didn't work out that we worked together at the time. We parted ways, but that planted the seed. And then I finished out my tenure with UHG last August. And at the end of which I was more in the Optum Labs area doing MSK, musculoskeletal R&D. Just had a chance to publish. Everybody's got a book or two in them, and it was part of my job is to let's publish these data
Yeah.
and push that out, which is a whole other story. You know, I'm not so sure that peer-reviewed literature is the source of truth that should be informing our decision making when you look at how biased and that ecosystem is. Wow, that was
Yeah.
an
That's
eye-opener.
sad,
It
right?
is sad.
It's hard to trust the reputable places that we used to trust anymore.
Oh, it's clear to me. That's not a world for me. But what was starting to happen was just growing more. restless personally with these practices that are creating such value in the system. Chiropractic practices, massage therapy, acupuncture, physical therapy, just creating enormous value in the system, helping patients significantly, and yet um, underserved by technology, largely using EHRs that are not interoperable. Well-intended. Look, I mean, the EHRs that have served that market, well-intended, visionary in their own respects to, let's apply technology to these practices. I'm not being critical.
Mhm.
The Achilles heel, though, is not interoperable. We'll come back to that later. And having come from the payer world, where these small, solo, in many cases, practices have no ability to negotiate anything. It's just take it or leave it. Here's your fee schedule, below Medicare, unchanged for 20 years, go for it. And as inflation's going up, labor costs are going up, labor volatility, you've got these super high value practices that are in this environment where they have no ability to influence and keep up with inflation through their reimbursement. Um, and so I just became more and more restless that, man, these terrific practices, great practice owners, they're savvy, smart, hustle, serving patients, trying to remain viable. Um, it just didn't seem to be a path that was getting traction. And so Garrett and I reconnected, like, what are you up to? How's it going? And, fortunate. He sort of welcomed me to join what they had started in Colorado Integrated Care Network.
Yeah.
We iterated on a vision of, hey, can we scale this, what is now beyond proof of concept with CICN, to bring this, nationally to these practices. And the whole thesis is underserved by technology, um, organized in a way that just this disparate, fragmented, isolated practices. And when structured in that way, they cannot participate in the system in a real meaningful way. As well intended as everybody is. So it just seemed to us that there's a catalyst. If you get these practices on the right technology that's interoperable, that's the irony. And, these practices are often called integrative practices,
Right.
but their technology doesn't integrate. And if your technology doesn't integrate, you're invisible to the system.
Yeah.
And so it's get them on a tech stack that's modern, it's interoperable, it's in the cloud, you can practice anywhere, anytime, and be present in the EHRs used by medical practices and big delivery systems. So you're behind the referral easy button. Okay, now you're integrated.
Yeah.
And if we organize you through, proper legal entity, such as a clinically integrated network that allows independent practices that are focused on population health and integrating in the system and adopt common technology, aggregate data, and are focused on improving value and quality collectively, you now can participate in types of contracts that allow you to um, appropriately participate in the value you're creating.
Right. It
It's,
was,
yeah,
go
go ahead.
ahead.
No, go.
Was there I mean, right, our fee schedule, our reimbursements haven't gone up in a long time. And you showed me something that was disturbing, being paid less than a hair cutter at
Yeah,
what Great Clips is the
yep.
reimbursement for chiropractic. I mean, is that intentional? Is that because we can't, negotiate collectively? What is behind that? Because I'm sure all physicians or other specialists have incrementally gone up, but also what we know about healthcare costs, physicians and clinicians are not the problem driving the costs.
No.
So what's held us back? Is that an internal job? Is that something else?
I and this is the question of the day, right? And I have to self-regulate my enthusiasm on this topic a little bit. But I was on a panel last week or the week before, American Chiropractic Association panel. I think it was part of their payer collaborative. Representative from Medicare was on. And so what I did, Mark, was grabbed 20 years of Medicare reimbursement history. Kudos to Medicare for publishing rates for 20 years.
Yeah.
All services, all providers. And to your point, chiropractic reimbursement has been unchanged in 20 years, flatline. So I plotted that. And, of course, Medicare has, it's a whole separate topic around coverage, and it's limited and only spinal manipulation and not other services. So there's some distortions in there, but just for the CMT codes, flat, PT is actually negative, a negative reimbursement over 20 years. And then I applied US inflation to that, right? Just the annual US inflation rate. And 98940, 100 CMS fee schedules comes in about 2864. 98940 with inflation adjustment for 20 years would be north of 42. And if chiros were reimbursed for simply 98940, 1 unit of therapeutic exercise, 97110, and a 99203 new patient eval with that cost distributed over 6 visits, that not adjusted for inflation would be 72. Adjusted for inflation would be 114. So the gap between 28 and 114 is what practices are facing.
Man, yeah.
And I am in need of a haircut, probably go this afternoon. My Great Clips bill is usually $30. So chiro's getting paid 28 to treat a Medicare patient. I go to Great Clips, I'm going to pay 30. This makes no sense, Mark.
Yeah,
And
right.
where this gets worse, that's a pejorative term, where this gets less understandable is in the commercial insurance market. We were guilty, Optum Physical Health, where we do the health insurance companies use entities like the Optum Physical Health business unit as an intermediary to develop the networks with these entities. And while we don't like CMS reimbursement, there's a math equation that leads to it. Sustainable growth rate, balanced budget amendments, RVUs. It's all a math equation.
Mm-hmm.
These intermediaries, it's just kind of a bit of a black box that benchmarks below Medicare and then holds that flat in perpetuity on a take it or leave it basis. So there's no ability to negotiate it. And, people lean on, well, we're coming in at 80, 90% of Medicare. Well, if Medicare is unchanged for 20 years, 90% of an unchanged makes 90% of $28 makes no sense.
Yeah.
Mark, it's really disturbing when you look at this. And to your point on some of the physician services in Medicare for the panel last week, I did plot E&M reimbursement over 20 years. New patient evals a little behind inflation, established patient evals a little ahead of inflation. So that is going up to where a percent of Medicare might mean something.
Yeah.
Chiro, it just doesn't mean anything, but that's the fallback. And it's not, there's a fundamental injustice, if you will, in these contracting approaches that service is creating such value for patients. Think about that. Unchanged in 20 years. It's now below the cost to deliver a visit, and it's less than the copay in many cases. So
Yeah.
patient has a $35 copay and they come in for $30, or they've given them $5 back, making change for the patient. This
Yeah.
doesn't make sense. Sorry, you got
I,
me wound up now, Mark.
no, that's good. I was hoping this would happen. Um, I mean, it almost seems like it's if they know we're providing value, not just us, but physical therapy and hands-on and
Yeah.
musculoskeletal costs, and at least in a self-funded plan, is 15 to 25% of the spending. It almost seems like I hate to sound conspiracy like a conspiracy, but like some sort of like why aren't we doing that? And then why aren't we increasing it? I mean, is it really to save money when the RAND study recently just came out looking at hospital costs, 225% of Medicare. I know with reference-based pricing, a lot of people are targeting 125% of Medicare, and we're 80, 90% below. It just something doesn't sit right with me on that. Like, why is it because, and I know you might not have the answer because we can't, not even just we as chiropractors, but PTs do much about it. We aren't united enough. We're not important enough. We're not, I mean, we're providing the value.
Oh, clearly, yeah. There's, um, I, there's no question we're providing the value, and
Yeah,
sort of what becomes the relief valve in some of this? It's patients paying cash for these services, and they're just going outside the insurance altogether and paying cash, and they do it at a high rate. And that's the ultimate endorsement of, hey, I really value this service that I'm willing to pay for it directly outside my insurance benefits. So there's value. Patients recognize it. Um, but and these practices are such an important part of our delivery system that if the system itself is starving these practices that are creating such value, ultimately this does not end well. And I guess the
right.
analogy I've been using recently, it's sort of like it's deferred maintenance costs on your house or your car, where we've just been putting this off, putting it off, putting it off, and eventually things are going to break. And yes, getting reimbursement more aligned with what keeps these practices viable and aligned with the value they're creating, it's going to be stair step. I mean, it's going to not be an incremental cost change. It's going to be material. But if you keep deferring the maintenance on this, that is what's going to happen. And, so my constant feedback to my network colleagues was we need reimbursement to keep reasonably well aligned with inflation because they're all experiencing inflationary pressures. And if we just keep this squeezed and flatline because we can and just take it or leave it with no ability to talk about anything, um, that's just not going to end well. And I think we're reaching that point, Mark, because these practices have labor pressure, they have labor cost pressure, and if their key billing staff leaves or key admin leaves, and they're really under pressure. And these clinicians should be doing what they do well, which is caring for patients, not worrying about how am I going to duct tape together some technology to keep myself viable.
Right.
It's
And
it's a you know this is not a sales pitch on a REIT because a REIT's not the only solution, but this is what we're trying to address. Modern technology, good technology, modernized operation, organized through proper legal forms, fully compliant, to be able to have conversations with self-insured employers, with medical groups, with payers to talk about the value we're creating for the system. Um,
I can't help but imagine that any of the bukas could care less because if, like you said, if people are paying out of pocket because they want it, they're probably like, good, go get it. It doesn't leave our wallet. And we're already doing that with the high deductible health plans, right? We're already paying what 10 grand a year in premiums, and then what $8,300, $7,500, whatever you're. So almost $20,000 of out of pocket expenses before you can access your insurance. And then if you want to go to something of high value that gives you relief, more out of pocket. It just seems like the root cause of moral injury for a lot of practices and damage to the the employer and the middle,
Yeah.
the mid market of people.
Yeah, this dynamic is inconsistent with what's been known for approaching 40 years now, that these practices create significant value in the system. Usually it's for the number one, two, or three cost category,
Yeah,
musculoskeletal
right,
complaints, not even considering the broader benefits on health and well-being that these practices create, which is real. But if you just look at MSK, clearly these practices are saving downstream total episode cost in a multiple of 2, 3, 4 to 1. And um, if you start moving all this outside the insurance benefit, um, some people, if you're, hey, great, awesome, if you're in an affluent, typically white zip code, that can
right.
terrific. I mean, that was one of the studies we did, was geographic variability in access to these therapies. And look, if you're in a low income and oftentimes non-white zip code, um, these practices almost don't exist because the economics do not allow for it, which there's other population health dynamics that crop up in those communities. So it becomes this great big um, issue that starts with economically viable level of reimbursement. I what it, what is interesting to us in this, and a little bit of serendipity, that we were connected to um, a platform called Venture, which is an individual contribution health reimbursement arrangement, which is a way for insurers to use pre-tax money, populate a health wallet that we as a consumer can now go shop for exchange-based plans, buy care directly. And man, to me, that seems really, really promising, where you start to um, reimagine what does insurance look like, and what's the role of an employer, and how do we arm consumers that are closer to all this with the financial incentives to make the right decisions. And super early for us, but really exciting, and comes back to employers have a really big role to play in this.
Right.
And how are they
ICRA,
caring for, yeah, and
right? You're
ICRA,
talking
yeah,
about
in this
ICRA?
case, it's an ICRA is a manifestation of that, which
Yeah,
we adopted as an employer. Our premiums went down, we got better insurance, and we're way more consumer mindset oriented on how we're shopping for insurance. It's kind of,
right,
or for healthcare, which is almost how you want it to be.
right.
And that's going to be a little bit disruptive. And that gets back to, man, the employers have a really important role here. And how do we configure this, the finances and the value of care in a community, to sort of best help our people, if you will, our employees and their families?
Yeah, I agree. Employers have a huge role. Maybe they don't want it, but they have it nonetheless, and they are in a healthcare business. I also think their advisors have a
Yeah.
big role in this
Yeah.
as well,
Oh,
and
yeah.
how they help design the payment model and the plan so that people can access or not access care easily. I mean, you got the
Yeah.
high deductible, that's hard. Kicking the can down the road because the premiums are going up is not solving anything. What I mean, like, what should we be discussing more with employers and brokers around how their role is crucial for good health for their members and
Yeah.
cost control?
Yeah. That's a big topic. I come back to your point. Boy, employers, really important role, a really hard spot in the typical traditional sort of group insurance model, where it's like, okay, I have however many employees, 10, 20, 50, 500. How am I going to go out into the market and evaluate all these group offerings, distill it down to one, two, or three options that I make available to my 500 employees, which ultimately becomes a lowest common denominator exercise, right? Which
Mhm.
group
Yeah,
plan satisfies most needs, but not all,
yeah,
but nobody really gets what they really need? What the ICRA does, which is beautiful. I mean, I'm still fascinated by this, is the employer sets a budget, says, hey, we're going to, put in $1,000 to each employee's health wallet. The employee then, armed with really great tools, goes out into the marketplace and can shop every exchange-based plan available. High deductible, low deductible, no deductible, high copay, low copay, different levels of coverage, platinum, gold, silver, bronze. And now, armed with funds from my employer as a consumer, I'm now shopping for the plan that makes the most sense for me and my family. And in some cases, some of that health wallet dollars we would use to go just buy healthcare directly in the market.
Mm-hmm.
And it starts to create more market-based supply-demand dynamics into healthcare purchasing, in that the consumer is really a consumer now. And the employer can feel good about, look, we're contributing money to this health wallet and bringing tools to our employees to help them, make a decision that's best for their family. Right now, everybody's buying the plan that makes the most sense to them. And they might buy down to a bronze because they want to spend a lot of money directly by going to a chiro for, twice a month, what's
Yeah.
called maintenance care, but it's actually important health care.
Right.
And if they do that and follow the lifestyle recommendations, maybe their burden of other, illnesses is down, and the bronze plan works fine for them. So it's just fascinating to me, this environment.
I hope that somehow this rolls into, you know, I just can't see it. Lower premiums,
Uh,
medical loss ratio, configurations somehow benefiting all of us, because I think the only place an employer has control in any of this, well, with exception maybe of the ICRA, but is in the self-funding, right?
yeah,
They can
yeah,
contract
yeah, right,
with
yeah,
direct contract, know what they're going to pay for things, choose the network, steer people that way, with hospital systems,
yeah.
reference-based pricing, kind of controlling costs. What are your thoughts on some of that? Like, really, I like what you're saying, because from the consumer end, but just at the top,
Yeah.
I can't see that that's going to make any kind of difference for us in the long haul. We're going to always keep paying more money for healthcare till death do us
I,
part.
I, yeah, um, so you asked the question, who benefits from lower cost? Um, and when you start to pull on that thread a little bit, and I was talking with an actuarial friend of mine not too long ago, does a lot of pricing. The whole system is built around stacking margin on top of increasing healthcare costs. And so all these stakeholders benefit as costs grow.
Yeah.
Payers, many types of provider groups, pharma companies, PBMs, everybody benefits as costs go up, financially. So, if your MLR is fixed, the only way to grow your bottom line is to increase the top line against the same MLR, so your IOI grows over time, right? So the system is designed, and the actuarial friend of mine, his comment was, nobody cares about increasing costs. We just want it to be predictably increasing.
Wow.
Which allows you to price against it and not have surprises, and
Mm-hmm.
and you get into publicly traded entities that don't want to surprise Wall Street and have predictable growth. That's how the system is really designed. I
Right.
think this is Dave's personal opinion, not being derogatory to any entity or payer or anything else. Um, who suffers in that kind of environment? Employer,
Yeah.
patients.
Yeah.
And to your point around self-insured employers have the potential to just pump the brakes on that a little bit and say, hey, we want to reimagine how healthcare is provided for our employees, which then you get into direct contracting, local ecosystem. How do we help all these entities work together on behalf of the employer and their employees? And bring more targeted resources to that ecosystem. Yeah, it's clear. I mean, from having gotten to know you, I think your head's there. It's clear that that's true. Um,
Yeah.
and within a REIT, that's certainly of interest of ours. Like if we string together a high value network of chiro, PT, massage, acupuncture on a common tech stack that integrates with the delivery system but can support an employer and their employees, I think that's an important part of this solution.
Right.
In whatever form that takes, whether the reimbursement flows through whatever the insurance coverage is, or direct from the employer, or in an ICHRA-like offering where patients can just pay directly with funds the employer's deposited in their health wallet. It's kind of all the above.
Yeah.
Yeah.
I have two questions before I get a little more into a REIT. You were with the innovation lab. Did you see any? Yeah, we keep hearing nonstop about digital physical therapy as the
Yeah.
solution for a lot of this. And I've been around healthcare 34 years, and I practice with PTs. I mean, hands on is great and it makes an impact, but I just don't, it's not the end all to be all for musculoskeletal pain.
Yeah.
And some of the reports I read sounds like it's an end all to be all. I'm curious if you ever had any interactions with any digital PT solutions with your time at Optum or United Health Group.
Yeah, quite a bit
Yeah,
actually. And we won't get into any names or any specific platforms. Um, but quite a bit. I recently Garrett and I have been spending a fair amount of time with a cognitive neuroscientist and understanding these manual hands-on therapies and how they impact people. And it's more than the adjustment moving a bone. It's more than dropping a needle in. It's more than the pure manual therapy. This is operating holistically, mind-body therapies, end to end, which when coupled with the setting and the experience, which is one of, compassion, safety, knowing the person, personal interaction with the front desk, and the effect that has on the amygdala to tamp down the pain response to help people function better. These therapies, it's a whole experience that the neuroscience benefits begin the moment they think about scheduling an appointment because it's such an experience, right?
yeah,
And then to think that you're going to replace all that with an avatar on a phone that tells you to bend this way or presumes to say, well, I can accurately measure your body angles, but if I move my phone a degree, it's like, that's sort of nonsensical on its face that these become the replacement and the be all end all for, replacing PT. I get there's a lot of VC and PE fluffing it up to get valuation so they can
right.
cash out and exit. So, I mean, that's an animator for sure. But what I will say is, and if we take the neuroscience approach, is once a personal relationship is established with a manual therapist who provides, which is really where a lot of the therapy happens, is what you do at home. And I now have technology tethered to the practice that's reminding me and nudging me and giving me advice. That becomes an extension of and an enhancement of the hands-on therapy. So there's a role,
Yeah,
no doubt, but it's not a replacement. That's my point of view on it. So I'm sure others would disagree. Uh, but when you get into the neuroscience, excuse me, when you get into the neuroscience of it, it does make some good sense. This does not create human connection and safety and reinforcement and everything that happens in the clinic.
right. Isn't it true? The whole is greater than the sum of its parts, and
Yeah,
you can't just distill things into ones and zeros with human beings.
yeah. We, well, um, the studies that come out on these things, they're really hard to do to know really who's using the technology, how often, how engaged are they, and the Achilles heel, I think, from my experience was they tend to skew to younger, healthier, already more active individuals, which when you really get into the science, and I'm no talented researcher by any stretch, but it's almost an insurmountable challenge to really carefully appraise the evidence on these digital tools. Is how
Mhm.
carefully did you create like cohorts and really understand that we have same on patient comparison.
In the last few minutes here, let's go a little
Yeah,
deeper on a REIT and the services you have, the states you're in, and how I can help you get connected with more self-funded employers. I really would love to see a REIT involved, knowing that the downstream costs are really mitigated quite a bit
yeah,
when you start with chiropractic for back pain. And the chiropractors I go to in my backyard here are CICN docs, and they
mm,
are great. They are great. I refer everyone to them. I've got multiple physicians referring to them now because I know their quality. I know they're great. They know what they're doing. They can diagnose. They're not going to overtreat. They're not going to refer willy nilly. So
yeah.
tell us a little bit about the network and where you're located and what you're up to with a REIT now.
Yeah, yeah. Thanks for allowing me to share that. It's as you mentioned, Ground Zero is Colorado. Garrett and some others. I mean, really visionary,
Yeah,
and they are exceptional clinicians. Boy, we have a chance to meet, talk. They're on some of our committees, and I mean, it's impressive. And that's largely been developed by word of mouth. As we socialize this more, a number of people are like, "Hey, we never heard of that." And I'm like, "Yeah, that's by design, because we want these high value clinicians that all kind of know each other.
yeah,
Bringing us in, introducing us, and so to your point, it's not the you know big PPO network kind of strategy. Um, it's like-minded colleagues introducing us, which is why you get that kind of experience you got, which is really exceptional clinicians, which
yeah,
we're just fortunate to be able to work with and support. So where are we? Colorado, Minnesota. Garrett and I will be in Texas next week. Uh, we're our ambition is to do this around the country, of course, and it's relatively easy to get in. We've got the legal entities in every market. It's an anchor, employer, payer, medical group, critical mass of providers that would bring us into a new group, and then we land and expand and scale.
yeah,
So the country is where we're shooting for. The tech stack, we spent a lot of time on this, and so we built this around the Athena electronic health record, which is really impressive. And this isn't an Athena ad, but when you look at the interoperability and all of the features and benefits embedded into that technology, it is impressive. The referral connectivity with medical platforms, if a physician is not on Athena, or on Epic or NextGen or eClinicalWorks, I mean, the ability to integrate, exceptional. Um,
yeah,
it vacuums up all the PDMP, the drug history, the labs tied into PAC systems, closed loop direct message referral connectivity. I mean, it is um, transformative for
yeah,
these kinds of practices. So that's sort of the backbone. Um, and then, as I mentioned, we've got a revenue cycle. Obviously, revenue cycle is key, right? The flow of funds through all this. And Athena is built on the U.S. bank platform, which just allows really efficient movement of funds. So in many respects, it's almost like a banking platform,
hmm,
which at that scale is important. We've got a revenue cycle group that works for us, Rev Upside, amazing revenue cycle business that knows Chiro PT and works for us within Athena. So as good as Athena is, they've not they don't have a lot of scale around Chiro, massage, acu. So Athena's willingness to have our group work within Athena on behalf of these practices, you know, important.
yeah,
Another Colorado group we're working with, OneCred, applying blockchain to credentialing to this idea. I mean, Mark, if you're contracted with 20 different payers, that every payer has to individually validate your same credentials,
Yeah.
and you're having to manage all these that makes no sense.
Right.
You're you. Your credentials are in your pocket. We should credential you once that then gets distributed out through blockchain kind of technology. So another part of our tech stack, and then Ventour we're bringing in to help practices with their own as employers health benefit offerings, and then string all this together uh, in a way that it's really easy for practices to turn on. And and once on the platform and you settle into your run rate, not have to think about this stuff.
Yeah. That's
And
great.
now I'm just there caring for patients, communicating with physicians, meeting with an employer about how we can improve value. Because all that other stuff is just not something you have to deal with.
Yeah.
That's really the goal.
Yeah, that's great because all we want to do is take care of people, not deal with
Exactly.
all that, and not deal with it all every year or every 2 years. To your point,
Exactly.
recredentialing. I remember when I left full time practice, I took a folder like this thick for all the insurance companies I was credentialed with, just so I could like not even cut and paste, but copy everything that
Yeah.
for the next year. When it was always all the same stuff, no matter who you went to. So
Yeah.
nice job. Dave, you continue to make amazing innovations. I got to give you a ton of kudos for doing what you've done to help our profession, multiple professions, lots of people. I think it's great that you realize that more research is not necessarily the thing that's going to make any big impact for anyone here. We know this is effective. It's been shown time and again. So kudos to you. I want to try to help a REIT grow into more self-funding. That's where I have some impact, and hopefully do some more work with what I see in our space: direct primary care,
Yeah.
Regenex, controlling. I love it when I can build, or when I'm involved in a health plan where there is good physical therapy, direct primary care, Regenex, and maybe a surgical center of excellence with
Yeah.
bundled care. Because my goal as a clinician is to kind of connect all those.
Yeah.
So to your point, we're all communicating, and people aren't falling through the cracks or going to the wrong
Yeah.
place or spending plan sponsor money out of network because their friend said go there, but that doc's only done 2 knee replacements in 5 years when
Yeah.
somebody else is a pro at it.
Well, and if you have a second, just to double click on that too, we
Let's do.
think part of our um, so back to the 33% of back pain starts with the chiro, and that's been the case for 30, 40 years.
Yeah.
And there's been this push in the profession around primary spine provider. We should be the primary spine provider, and everybody should start with us. We absolutely are opposed to that positioning. We think that these high value practices on the right technology being a resource to support primary care physicians and to support specialists is the right positioning, because inevitably a lot of back pain is going to go to their primary care physician. That's who they trust. That's the safe entry point.
Yep.
Let's not try to change that, but let's come in behind that and collaborate with and support and integrate with primary care to be a resource where once they've evaluated, it's just a push button away that they can connect patients to the care their own ACP guidelines recommend the patient should be getting.
Right.
So don't try to disrupt the front door, but be a support resource to primary care, because that primary care model makes a ton of sense on a lot of levels.
I
Yeah.
agree. I mean, I made my way through the struggles of early career saying, where are the physicians? Where are the patients? They're
Yeah.
with primary care.
100%.
And so, my story. I went to the largest primary care group here in Colorado and went in house with them.
Yeah.
And that opened up the doors. And then I went in house with the largest pain management group here in Colorado, and then the largest Ahmed provider in the country. And eventually just built that trust. They had the patients, and I went from the back of the line where they just send me their failures, which was like my intro, just give me your failures, to the front of the line where that primary care
Yeah.
doc comes down the hall and says, "Hey, I just saw this guy. Can you see him now?" Instead of waiting till they've done everything else and then send me their
Ex-
failures. So it's the right way to go.
It is. And then you've come full circle because you're not the quack anymore. you're their trusted colleague and resource, right?
That's
So it's
right.
right back to the opening, and that's exactly the positioning.
Yeah.
It's
Good for
beautiful. Yeah.
you. It is. Well, thank you so much. I appreciate this. You got a wealth of knowledge. You're doing awesome work. How can people reach you?
Well, I used to have my background up. Let's see. So I think probably, Dave at Healthcare
All right.
or www.arete.healthcare, one or the other.
That's
Mark,
that's
thanks for
great.
the invite. I really appreciate it. Enjoyed the time together.
Likewise, Dave.
All
All
right.
right. Well, thanks everyone for tuning in, and look for more in the future.